atherosclerosis of the coronary arteries. So in the symptoms of ischemic heart disease, the most common symptom will be chest pain, most common symptom. And the typical features of this chest pain, it will be the site of the chest pain. The chest pain is most common site is retrosternal, most common site. The nature of the pain: for the ischemia or anginal pain is it is a dull and constricting in nature. Third point for this pain is the radiation of the pain. This pain, myocardial infarction or angina, you can say it is a type of inflammation. So they will stimulate the nearby nerves. So because of the stimulation of the C8 and T1 nerve roots, so it is a type of inflammatory process, the myocardial infarction. So the pain will radiate to C8 and T1 distribution. It will radiate to left arm and forearm. Now coming to the aggravating and relieving factors. So the pain of the ischemia is done under 5 headings. The site retrosternal, nature is dull or constricting, radiation is left arm and forearm. While the aggravating factors, it is the cold temperature. What does cold temperature do? It causes the coronary vasoconstriction. So that means majority of the cases of myocardial infarction occur in the winter season. So blood supply is reduced because of the cold temperature, and aggravating factor will also be exertion or increased exercise. And exercise increases the demand of the blood supply. So there are two pathogenesis. One is decreased blood supply is reduced, again demand is increased. So they will lead to the ischemia or the we can say myocardial infarction. The relieving factors: opposite of these relieving factors is there will be the coronary vasodilatation. So sublingual nitrate, it causes coronary vasodilatation. And second is rest, because it decreases the demand. So these are the characteristic of pain, and majority of the question that you will be doing in the MCQs, the clinical case is written, the typical anginal pain is mentioned. These are the typical features of a anginal pain. But sometimes what can happen in cases of autonomic neuropathy patients, when there is a autonomic neuropathy, pain is not manifested. That is known as a silent angina or silent myocardial infarction. So these cases are, if, and this is the exception, if there is autonomic dysfunction, there will be painless MI or painless angina when there is a autonomic dysfunction. And why this point is important? Because one of the cause of autonomic dysfunction and also predisposed to the myocardial infarction or ischemic heart disease is diabetes. So in diabetes patients, we will not rely on the chest pain because chest pain will be absent in these cases. So autonomic dysfunctions like diabetes patients or maybe elderly, there will be a painless angina. So in this case, we will look for some anginal equivalents so that we can suspect that patient is having the angina. So in that patient, when there is autonomic dysfunction, we will look for or watch for angina equivalents symptoms. We look for the anginal equivalent symptoms. So these anginal equivalent symptoms in cases of diabetes patients, these are anginal equivalents is unexplained breathlessness. There is no reason why painless is because of autonomic dysfunctions. Autonomic dysfunction, pain will be absent. So we will look for unexplained breathlessness. There is no other cause of breathlessness, like there is no asthma, no COPD in the patient, even then patient has breathlessness. Then second point we will look for is unexplained sweating. Unexplained sweating, like in diabetes, one of the cause of the sweating could be hypoglycemia, so that has been ruled out. Even then patient has sweating, suspect the myocardial infarction or angina. Or it can be unexplained sense of impending doom. Sense of impending doom, like ghabrahat. In Hindi it is called as the ghabrahat. Will hot application reduces the pain? No. Remember, hot application will reduce the pain of musculoskeletal inflammation, like muscular inflammation or joint inflammation. That will be reduced by hot packs, not the anginal pain. So we will look for these anginal equivalent symptoms in the patient. Now come to the signs of the disease. Signs after the symptom. So some of you must have seen the patient of myocardial infarction coming to your emergency. So how the patient comes? Patient will come and keep the fist on the retrosternum. The patient comes like this. So keeping the or holding the fist against the retrosternum, indicating the location of the pain, a diffuse location of the pain, is known by a name of a sign. So the most important sign here is the Levine sign. Levine sign means holding the fist on retrosternum. Holding the fist against the retrosternum like this to indicate the location of the diffuse location of the pain. Now come to the pulse and JVP, and let's see how they will be useful to us. Even before doing the ECG, we can diagnose which side of the heart is involved in infarction. So come to the first one is pulse examination under the sign pulse. So in the pulse, if there is two abnormalities of the pulse, if there is bradycardia, explain impending doom. Impending doom is, you can correlate When you are not prepared for your viva and you are going to give your viva and examiner is very strict, so that feeling is known as sense of impending doom. Now, if pulse shows bradycardia or tachycardia, or the tachycardia. So with this, we can diagnose which part of the heart is involved, bradycardia or tachycardia. So if it is a case of bradycardia, that is heart rate is less than 60. So in this, we will suspect that it is inferior wall MI. Suspect it is a inferior wall MI. Inferior wall MI. But why bradycardia is seen in cases of inferior wall MI? There are two reasons for it. The first reason is SA node and inferior wall, both these parts, SA node and inferior wall, are supplied by right coronary artery. They are supplied by the right coronary artery. So that means there will be the involvement of inferior wall as well as the SA node. So it will cause a bradycardia. SA node functions will reduce. SA node functions will reduce. So this is the first reason. Both are supplied by a same artery, that is a right coronary artery. And the second reason is also the reason for the bradycardia is a myocardial infarction is a type of inflammation and it will lead to stimulation of nearby nerves. Infarction is a type of inflammation and it will stimulate the nearby nerve, and the nearby nerve near the inferior wall is vagal nerve, so it stimulates the vagal nerve. Bradycardia. So there will be bradycardia will be present. Heart rate will be less than 60. Now come to the tachycardia. So if bradycardia is there, the SA node is involved too. Yes, SA node will be involved too. That will suggest the common blood supply. Now what about the tachycardia? If patient has tachycardia, we will suspect that patient has anterior wall MI. Anterior wall MI, and anterior wall MI they present with tachycardia. Reason is in the anterior wall MI there is a stimulation of nearby anterior wall, nearby thoracic nerves. And what is the thoracic nerve outflow? Sympathetic. Yes, pulse can also be normal. This is not a very hard and fast rule. So anterior wall MI, there will be a stimulation of nearby sympathetic nerves, and tachycardia will be there. So remember, do not forget these basic signs even in a disease like myocardial infarction. Now come to the JVP, jugular venous pulse. So next sign, JVP. So if JVP is raised, remember, suspect that it is a case of JVP. Remember, JVP is a measure of right atrial pressure. This is a very basic. It is a measure of right atrial pressures. And how will the right atrial pressure will elevate in myocardial infarction? If there is a ventricle failure. So ventricle failure transmit the pressure to the atria. So it is suggestive of right ventricle myocardial infarction. Right ventricle myocardial infarction, as RVMI leads to ventricle failure, and because of the right ventricle failure, pressure transmitted to right atria. Transmitted to the right atria. So JVP, if it is raised, so always suspect it is a case of a right ventricle myocardial infarction. Right ventricle myocardial infarction. How to measure the JVP? The JVP is a measure that we will be discussing in your cardiovascular classes. When SA node ischemia is involved, will there be no sinus tachycardia? No. If SA node is involved, there will be no sinus tachycardia. Now, RVF means right ventricle failure. It means right ventricle failure. Now, come to the heart sounds. Important heart sounds. So the in the heart sound, with the help of these heart sound, we can also diagnose the site of the myocardial infarction and the complication of the myocardial infarction, that we can diagnose in the particular heart sounds. So the heart sound is this is a basic of the heart sounds, that is S2. Remember, S2 has two components. One is A2, second is P2. And they will come, the A2, that is a aortic valve closure. Occur when left ventricle has ejected its blood. So remember this basic. S2 is equal to A2 and P2. A2 is the closure of the aortic valve, and when will the aortic valve will close? When left ventricle has ejected its blood out, while P2 is pulmonary valve closure. And it occur when right ventricle has ejected its blood. So normally aortic valve closes earlier than the pulmonary valve, because time taken by the left ventricle is less to eject the blood than the right ventricle. So time taken is less, hence A2 comes first in the cardiac cycle. Now come to the how we can diagnose the site of the myocardial infarction with the help of these two sounds. So if there is right ventricle myocardial infarction, so understand this carefully. If there is a right ventricle myocardial infarction, right-sided MI, so what will happen? There will be right ventricle failure will take place, and if right ventricle failure take place, right ventricle will take more time to eject its blood out. So there will be late P2. There will be late P2. So in right ventricle MI, there is a right ventricle failure. And if the right ventricle failure is there, right ventricle will take more time to eject the blood and there will be late P2. This means the S2 split. S2 split time will increase. The distance between these two sound will increase. S2 become wide. S2 will become wide because the P2 is coming late. Yes, it is a wide split. This is a wide split which will take place if it is a right ventricle myocardial infarction. But what will happen other way around? If it is a left ventricle MI, so we will expect left ventricle failure will take place. Left ventricle failure will take place, and when there is a left ventricle failure, there will be late A2 sound. And this late A2 will be later than P2. Later than the P2. So what will happen in the cardiac cycle if A2 is coming later than the P2, like this? You can visualize the diagram. A2 is coming later than the P2. It is known as the reverse split of S2. So this will lead to reverse S2 split. Yes, S2 split will become reversed. So S2 is a very important sound. S2 is a very important sound that will help us in determining the which side of the myocardial infarction is there. Reverse split, yes, very good. Reverse split is also known as the paradoxical split. That is synonym. This is known as the paradoxical split. Paradoxical split. Now, coming to how to differentiate between A2 and P2, that we will do in the examination portion. That is very easy to differentiate. Now, come to the next heart sound of importance, and next sound is the pericardial rub. Of importance, pericardial rub in the heart sound. So basically pericardial rub is due to rubbing of two inflamed layers of pericardium. So if a pericardial layer get inflamed, their surface will be rough. So they will rub against each other. So it will produce a crackling sound. It will produce a crackling sound known as the pericardial rub. So pericardial rub, why it occur in the myocardial infarction? There are two reasons. So pericardial rub, it is due to two reasons. So it is due to number one, it is because of acute pericarditis reason spread of inflammation from myocardium. And this acute pericarditis can happen. This is due to the spread of the inflammation from the myocardium to the pericardial layer, and it occur on the day 1 of the MI. So this is seen on day 1 of MI. day 1 of the MI. So this is known as the acute pericarditis. Acute pericarditis. So the other one, there will be, yes, very good. The chronic complication. This is known as the chronic pericarditis. So there will be second reason, and second reason is chronic pericarditis. It is basically a hypersensitivity reaction. And it usually occur in 4 weeks time. So there is a range, there is a full range. So 2 to 4 weeks. 4 weeks after MI, hypersensitivity reaction. Hypersensitivity reaction occur after the myocardial infarction, and this hypersensitivity reaction is a delayed. It is a type 4 hypersensitivity reaction, delayed hypersensitivity reaction. Yes, it is a type 4. Type 4. So this syndrome, a very, very important question comes. This syndrome is known as hypersensitivity reaction, Dressler's syndrome. This is known as a Dressler syndrome, delayed hypersensitivity. Now, this hypersensitivity spread in other parts of the body also. So, how to remember this Dressler syndrome? A very important question after the myocardial infarction. So, Dressler syndrome is characterized by 4 P's. Type 4 hypersensitivity reaction. So, Dressler syndrome, first is fever, that is pyrexia. Pyrexia. Then second is pericarditis. Pericarditis. Hypersensitivity towards, the main reason is hypersensitivity towards the products which are released from the myocardial muscles from inside. They come into the blood. So hypersensitivity will be against those products which are released from the inside the cells. Then pneumonitis and pleuritis. Pleuritis. So there will be a pericardial rub. There will be a pericardial rub because of these 2 reasons. First rub can be on the day 1 of the MI, and second can be up to 4 weeks after the MI, pericarditis. Now, coming to the murmurs in the examination finding, important ones. Murmurs, and these murmurs are due to complication of MI. Due to the complications of the MI, and these complications usually occur on 3rd to 5th day of MI. Usually occur on pleural rub will also be seen. Yes, there will be pleural rub also because of the pleuritis. What is pneumonitis? Pneumonitis is the inflammation of the lung parenchyma, is known as the pneumonitis. Now, how to differentiate them two clinically? Very easy. If you have features of multi-system, then it is a Dressler syndrome, and if you have only cardiac manifestation, then it is acute pericarditis. The onset is also important. Day 1 is acute pericarditis, and after 1 month is Dressler syndrome. Now, murmurs. Murmurs is, it is due to the complication of myocardial infarction, mainly the necrosis leading to rupture of the tissue. Necrosis leads to rupture of the myocardial tissue. So there will be 2 important complications. First complication is papillary muscle rupture. papillary muscle rupture, it is not able to hold the mitral valve. Papillary muscle stabilizes the mitral valve, so it will lead to mitral regurgitation. It is acute. It is acute. So mitral regurgitation will be seen, and mitral regurgitation is due to papillary muscle necrosis causing the rupture. And second complication can be because of the interventricular septal rupture. And this will lead to ventricle septal defects. VSD. So there will be a VSD which will be created here because of the septal rupture, and there will be acute mitral regurgitation which can be seen here, and they will produce the systolic murmurs. They will produce the systolic murmur, which we will be discussing in the examination section. So these are the two important. How does papillary muscle get rupture? Papillary muscle get rupture because of the infarction leading to necrosis. Necrosis leads to rupture. The tissue will rupture when there is a necrosis. So these are necrosis induced. Necrosis induced. So remember, MI clinical findings are also important. It is not only you see the ECG and manage the patient. These are also important as a clinician. Now come to the investigation. So in the investigation of myocardial infarction, investigation point, of course, first is the ECG. Very important. Because as intern or as a primary care physician, you should know how to look at the ECG, how to diagnose some serious condition. So at least you will be able to refer the patient. That is expected from you. Ki looking at the ECG, you should refer the patient if it is a case of any ischemic heart disease or any myocardial infarction. So in the ECG, we will discuss two things. First is the ECG changes, and second is the localization of wall of MI. Wall of the MI. So these are number one, the changes here. Sequence of changes. So the sequence of changes and mechanism. Sequence of the changes and mechanism. And whatever are these sequence of the changes, they are defined for ST elevation MI. They are defined for the ST elevation MI, whatever we are seeing here. So the sequence of the changes, number one, it is considered as the earliest change. And earliest change is because of the potassium leak out of the cell So because of the infarction, the membrane permeability is increased. Membrane permeability is increased. So that will lead to the potassium which is leak out of the myocytes. So this will mimic hyperkalemia change. This will mimic the hypokalemia change, potassium leak out of the myocytes. So the earliest change here will be, this will be the change. This will be the change. So this change is known as the tall T wave. So this will be known as the tall T wave. Earliest change. So this phase is known as the hyperacute MI phase. This is known as the hyperacute MI phase. MI phase. And remember, there is no fixed timing. Stage 1 changes to stage 2. There is no fixed timing. This is only the ECG changes which determine the stage. Now coming to it will cause the second change. It will be the second change now. So the second change will be, the mechanism is still hypothesis. Remember, these are still hypothesis. So one of the hypothesis for second sign is, it is due to early repolarization of infarcted myocytes. So there will be metabolic changes and there will be early repolarization of the infarcted myocytes. So what does that mean? The early repolarization. Early repolarization is a repolarization of the ventricle start with the ST segment. So the ST segment will start early, even before QRS is complete. So what does that mean? It means that ST segment will start even before QRS is complete. Even before the QRS is complete. So in which lead, that we will see in the second section, localization. Which wall is affected. So whatever wall is affected, that particular area will be show these changes. So early repolarization of the infarcted myocyte. So ST segment will start even before the QRS is complete. So here it will be so this is the extension. This is the diagram, diagram of number 1 phase only, but I have marked the dotted lines. So what happens? The ST segment will start even before QRS is complete. So what will happen? This ST segment This ST segment will start from here and it will then join the tall T wave like this. It will join the tall T wave like this. Or to be more precisely, so this will become the tombstone or gravestone ST segment. So this will produce a convex, and why convex upward, reasons are still not known. Convex upward ST elevation, which you have done earlier, it is known as the gravestone ST elevation. Gravestone ST elevation. Tombstone. So this is a sign of acute MI. Acute MI. Now number third sequence will be, there will be ischemia of surrounding area. There will be a ischemia of the surrounding area of the infarcted tissue. So what will happen? The T wave will show inversion. The T wave will show the inversion. So ST segment elevation will remain, and there will be T wave inversion. So along with ST elevation, T wave inversion will start occurring, and this is known as evolving MI, known as, we have done, Pardee sign. This was known as the Pardee sign. When there is the evolving MI, the T wave inversion also started. Yes, very good. Ischemia of the surrounding area. So this will be evolving MI. Number 4. Number 4 is the phase number 4. And in this phase, there is a necrosis. Necrosis occur of that infarcted area. Necrosis is occurring, and how does the necrosis lead to the ECG sign? And this phase is known as evolved MI. MI has evolved. Now there will be no role of giving the thrombolytic agents if number 4 phase has come, because necrotic tissue we can't make it viable. So this myocardial infarction, how to differentiate between tombstone and Pardee sign? Tombstone will not have any T wave inversion, but here in Pardee sign there is a T wave inversion. So these will lead to evolved MI or necrosis. This will be the sign. ST returns to normal. T wave become upright. Or in some cases, or remain inverted. So ST segment returns to the baseline and T wave will become upright. But a very important sign which can be seen here is you can see the first wave, wave before the R wave is Q wave. So the main important pathology here is this wave. This is the wave, and this wave is known as pathological Q wave. Also important question. Normally Q wave is present, but here it is known as pathological Q wave. And pathological Q wave is defined if depth is more than 25% of R wave. Yes, this is known as the pathological Q wave. Pathological Q wave. Tombstone sign, remember in the tombstone sign the ST segment is taller than the QRS. Therefore, I have drawn it again. The ST segment is taller than the QRS segment. That is the meaning of a tombstone sign. Tombstone sign. So these are the four phases along with the myocardial infarction usually develop. But this is not a rule. Sometime the Pardee sign may not be seen. Remember, Pardee sign may not be seen. So therefore, these are theoretical explanations. All the stages may not be seen. All the stages may not be seen in this sequence. Now come to the again a very important section is localization of MI. So come to the localization of wall of MI. Localization of the wall of the MI, which lead should we look for that particular thing. And yesterday I told you that you should read the coronary blood flow of the heart as well, because such questions also will come. Applied anatomy, which wall is supplied by which branch of the coronary artery, and which lead you will see that thrombus. So the localization of the wall of the MI. So what I will do, I will draw a diagram. This is a vertical diagram of the heart. Localization of the MI. This is a vertical and vertical localization. Duration of these changes, as I told you, the duration is variable. It is not a fixed duration. It is not a fixed duration. Now come to the branches. So this I have made a vertical diagram or vertical plane of the heart seen from the front, vertical. And in this, the first branch here is, this is a left main coronary. Left main coronary artery. This is a branch arising from the aorta, and it divide into two branches. This branch which is going towards the lateral wall and then turning to supply the posterior wall, this is known as circumflex. So this is known as left circumflex. Left circumflex artery. And it supplies the lateral wall, and turning back supply the posterior wall as well. So, and this is left anterior descending. left anterior descending, and left anterior descending supply the anterior wall. It supply the anterior wall of the heart. Now there is a right coronary also originate from the aorta. Right coronary originate from the aorta separately like this. Like this. So as seen from the front, this is the right coronary supplies. So right coronary originate from the aorta. So this is right coronary artery. And the main branch go behind the heart and turn inferiorly. So it turn inferiorly. So the branch, main continuation branch, which is going and supply the inferior wall, is this branch. Dotted is the branch which is going back and supply the inferior part. This is known as posterior descending artery. Posterior descending artery. And there is a branch which is going to supply the right ventricle directly, and this branch is known as the marginal, right marginal. This is known as the right marginal. So these are the arteries which supply the heart, main branches supplying the heart. Now if we look at in this vertical plane, the walls. So remember this wall is inferior wall. This is an inferior wall, and very well you can see this inferior wall is supplied by the right coronary artery branch, that is a posterior descending artery branch. So this is detected by the inferior wall will be detected by the lead which are placed here, and the leads which are placed here are lead 2, 3, AVF. So these are the leads which are placed here, and these leads will diagnose posterior descending artery thrombus, that is a inferior wall. It will be supplied by. Now the high lateral wall is this wall here. Lateral wall. So this lateral wall, right marginal, supplies the right ventricle. So I will write it here, right ventricle. Directly. So the lateral wall, high lateral wall we can also say, and high lateral wall is supplied by the left circumflex. If you can see the branch, left circumflex, and here the lead on the left upper limb will be 2 leads in a vertical plane, and these leads are lead 1 and AVL. Lateral wall in the vertical plane. So if we want to look at the lateral wall MI in a limb leads 1 and AVL, inferior wall MI, inferior leads 2, 3 AVF. Yes. Now come to the very important again a diagram, and I will take a transverse section and four main branches will be taken in that transverse section. So look at this transverse section carefully. This is the transverse section here. At this line, I am cutting the ventricles and I will see in a thoracic cavity from above. So visualize the three-dimension plane, three dimensions of these coronary artery supplies and the chest wall So at this level, I will take a transverse section. So this is the transverse section now. Transverse section, or you can say a horizontal plane or a horizontal plane. So this transverse section is transverse section, posterior and anterior part is the sternum, and the cut section at the level of the ventricles. Our heart is slightly obliquely placed. So this will be the position of the heart in the transverse section. So the position of the heart in a transverse section. Septum is oblique. This is a septum. It is obliquely placed. Septum. So there will be right ventricle this side. This is right ventricle. This has got a thin wall, very thin wall. Right ventricle side, and the other will be a left ventricle side. So this is a slightly thick left ventricle side, Left ventricle. So this is the position of the heart in a transverse section. There is a septum, right ventricle side, left ventricle side, obliquely placed. Now coming to the arterial supply of the heart. So here is, if I will start from the right ventricle side in the transverse section, here is the artery. It supply the right ventricle wall. Here is the artery. supplying the right ventricle wall, and this is RM, right marginal. This is right marginal. This is right marginal. So this will supply the right ventricle wall. This will supply the right ventricle wall. Now here is posterior descending artery. Posterior descending artery. It is going behind and then turning inferiorly. Posterior descending artery. Here is circumflex. Left circumflex. So you can see in this diagram, starting from the right side, right marginal supply the right ventricle wall. Behind is posterior descending artery. It supply the posterior part of the septum. And on the left side is left circumflex. It supply the lateral wall as well as the posterior wall. It supplies the posterior wall as well. And here is LED. So LED is supplying the septum as well as the anterior wall like this. So these are the blood supplies. So this is the transverse section of the heart. That is right marginal, right ventricle, posterior descending artery supply the septum, left circumflex supply the lateral wall and the posterior wall. LED supply the anterior wall and the septum. So this is the blood supply of the heart. Now come to the ECG leads. So if we look at the ECG leads which are placed on the chest wall, here are the position of the ECG leads. This is V1, this is V2 on the chest wall. This is our basic number 4, placement of the ECG leads. Then V4, V3, V4 here, V5 and V6 and the V6. So these are the placement of the leads. So on the sternum, we put the right of the sternum is V1 and left of the sternum is rest of the chest leads. So this is a cross section. Now understanding this diagram anatomically is very, very important, because what is the site of the MI we can determine with this ECG leads. So for that we will complete a table on the basis of this diagram. That table is the site of the MI, artery involved, and the ECG leads to detect that site. So for streaming we'll take 2 minutes of break here. All right. So coming back to this diagram, the horizontal diagram of the heart with their blood supplies and the placement of these ECG leads. So whatever is the label on the diagram will be the label on the table. So I will make a table of 3 columns. That is the site, artery and the lead. So starting with the first site which is affected, number one site, and it will be same as the site in the diagram, number one. Here it is affected, number one. So this site is anterior septum. This is the anterior septum. So number one site, anterior septum. So if even if anterior word is not written, but only septum is written, septal MI. So the artery involved here is LAD, left anterior descending artery, and the lead, the best lead which is near to the septum, which will be there. And in this diagram you can see the nearest is V2. So the best lead here is V2 lead, but sometime changes can also be seen in V1 or V3 also. So V2 is the best lead, and I'm writing the best lead in the red color, or other lead which can be showing a septal is V1 also, and sometime V3 also. You can see the position of these leads. Now coming to the number two site, and number two site is this wall, number two. This is the wall which is affected, and this wall is anterior wall of left ventricle. Anterior wall of the left ventricle. Number two, artery supplied LAD. And the best lead for number two, you can see, is V3 and V4. V3 and V4 are the best for LAD. And sometime changes can also be seen in V2. Can be seen in V2. Now come to the number third. Number third. So number third is a lateral wall of the heart. Lateral wall. This wall is supplied by left circumflex. Supplied by the left circumflex, and the lead which we will see, it will be seen in V5, V6, as well as 1 and AVL. Lateral wall. While coming to the fourth wall, and fourth wall is normally not detected by the standard ECG leads. It is not detected by the standard ECG leads. So number four. This is posterior wall. Supplied by left circumflex, and this lead is not there. So what we will ask the technician, to place 3 more chest leads in the fifth intercostal space, and those chest leads technician will place, and these leads are 3 more leads technician will place. These are known as extended chest leads. These are known as the extended chest leads. So these leads will detect the posterior wall MI, and these leads are V7, V8 and V9. So these are not standard, these are extended. So the leads will be V7, V8 and V9. These are the leads. Extended chest leads are placed in fifth intercostal space beyond the V6, fifth intercostal space, and till the scapula they will be placed at equal space. Now coming to why you will suspect the posterior wall MI? How will you suspect the posterior wall MI? When will you ask the technician to place the posterior leads? Important phenomena here occur, and that phenomena is, before going to the number fifth site, an important phenomena is if ST elevation is seen in particular wall leads. Remember this phenomena. If ST elevation is seen in any particular wall leads, there will be a chance that there will be a reciprocal ST depression in opposite wall leads, just like a mirror image. So if ST elevation is seen in a particular wall leads, there will be reciprocal ST depression. Reciprocal ST depression means mirror image change in the opposite wall leads. So for example, if ST elevation is seen in the posterior wall, example posterior wall leads, there will be reciprocal ST depression in this example anterior wall leads. So there will be a reciprocal change. So this reciprocal change will be seen in V1, V2, V3 or V4. So this is a reciprocal ST depression which will be seen in the anterior wall leads. So this is a phenomena of reciprocal changes. So posterior wall V7 to V9 we'll see ST elevation, but in anterior wall leads like V1 to V4 we can see ST depression, reciprocal changes. So make it a point that whenever this is a mirror image change, which is seen, as simple as mirror image. So remember, make it a point whenever you are seeing. So remember this point, whenever ST depression in V1 to V4 is seen, whenever ask the technician to place V7 to V9 leads. So place V7 to V9 leads. If V7 to V9 shows ST elevation, it is a posterior wall MI. But if ST segment is normal in these leads, then it will be a case of anterior wall, non ST elevation MI or angina. This is how we differentiate. This is the flow chart that you have to see how it is a ST elevation of posterior wall MI, or it is just the non-ST elevation MI of anterior lead or angina of anterior leads. So you have to take the V7 to V9. So this is how to make the diagnosis of posterior wall MI. Now coming to the right ventricle wall MI, come to the fifth. Number fifth is this site. Number fifth is this site. Remember D Winters T wave. D Winters T wave is seen in a few cases of LAD block leading to the infarction. That is in a few cases. And these are the typical cases. So number five, right ventricle free wall MI. It is supplied by the right marginal. So here the right marginal will be blocked, and if you can see, V1 will be the lead, but that is also slightly far away, may not be sensitive. So what we will do to detect the right ventricle MI, we will ask the technician to remove left side lead and place them on the right side. So we will ask, in cases of suspected right ventricle MI, right sided chest leads will be placed. In right sided similar intercostal spaces. So we ask the technician to place them on the right side. And how will we suspect a right ventricle MI? When we get a right ventricle failure signs like a raised JVP, like we have done in the clinical examination, a wide S2 split, raised JVP. So that will be suggestive of a right ventricle MI. Bradycardia will also suggest a right ventricle MI. So ask the technician to place them on the right side. And on the right side, the best lead or the nearest lead to right ventricle is the right sided V4. So here R word will be written, so V4, and there will be R word written, maybe before or after V4. Maybe before or maybe after. This lead will be the most sensitive lead to diagnose the right ventricle MI. Now coming to the this was the very important, the localization of the myocardial infarction and particular leads. Coming to the cardiac marker, the second test which is done is cardiac markers. So, what are the cardiac marker? Cardiac marker are basically the enzymes or proteins which are inside the myocyte, and due to infarction they are released. They are released and detected in the blood. Detected in the blood. Inferior wall we have done in the vertical diagram above. In the above. Now, coming to the cardiac markers, and cardiac markers time to increase, time to get detected. Remember, after symptom onset. After the symptom onset. So, this will be time to normalize. Time to normalize. And the cardiac specific markers, there are three important cardiac specific markers. Number one cardiac marker is, this marker is detected in 30 minutes after the symptom onset. 30 minutes, and it normalize in 24 hours. Normalize in the 24 hours. So there will be the marker within 30 minutes is heart type fatty acid binding protein. Heart type fatty acid binding protein is the protein inside the myocyte, and it is released within 30 minutes after the chest pain, and it normalizes in 24 hours. Number two is CPK MB. CPK MB. Now, this CPK-MB, it is detected in say 5 to 6 hours after the onset of the chest pain, and time to normalize is 72 hours. 72 hours. Number third is troponin I or T. Troponin levels. Troponin are the proteins, cardiac proteins, and time to get detected is 5 to 6 hours. Normalize in 10 to 14 days. 10 to 14 days. How to detect heart type fatty acid? Blood test. Blood test. So these are specific. Remember, myoglobin, SGOT, LDH are non-specific. So SGOT, myoglobin, and the LDH are so non-specific that we do not go for those tests. Now, the importance or the disadvantage of these tests, number one is heart type fatty acid binding protein is non-available. It is not available everywhere. That is the main problem with this protein. While the out of CPK-MB and troponin INT, this troponin INT, they are best marker, both in terms of sensitivity and specificity. Sensitivity and specificity, troponin are better than CPK-MB, better than the CPK-MB. What is the role of the CPK-MB? Role of the CPK-MB is they can detect reinfarction within 3 to 10 days. What are the ECG changes of reinfarction? Again, same changes. ST elevation. ST elevation. NA is non-available. They are not available everywhere. They are not available everywhere. So these are the markers with their relative importance. Hard type fatty acid binding, though it is the earliest to get detected, but it is not available. Best marker that we use these days is troponin levels, INT, and CPK-MB. They detect the reinfarction between 3 to 10 days. 3 to 10 days. Because in 3 to 10 days, previous level of troponin may be elevated. Now, coming to, so these markers are specific for MI, relatively specific for the myocardial infarction. Now, coming to the approach to make a diagnosis of these ischemic heart diseases based on the clinical history, ECG, and troponin. Based on these, so here is the flow chart to make a diagnosis. So, approach to diagnosis of ischemic heart disease. Approach. So approach is number one, patient coming to you with a anginal pain. So the number one is, if a patient presented to you with anginal pain, typical 5 features of the pain will be there. So in that case, patient comes to you in emergency. The next step will be you do ECG. Very, very important. Within ECG within 10 minutes of arrival in hospital. So patient has an anginal pain. Come to you in the emergency. So within 10 minutes, do the ECG of the patient. This is a protocol. These are the guidelines. Now, in the ECG, two main parameters you will get. First is, in the ECG, there will be either ST segment depression can be seen, or ST elevation can be seen. So step-wise approach, a clinical approach. Patient is coming to you. So there will be anginal pain, ECG is done, ST depression or ST elevation. ST depression means it is a subendocardial injury. Subendocardial injury. And if it is ST elevation, it is a transmural injury. So patient is coming to you with anginal pain. ECG will have two results. ST depression we have done. ST depression significant is 0.5 mm below the baseline. ST elevation, it is 1 mm above the baseline. ST depression represent a subendocardial small injury. ST depression. ST elevation represent a transmural injury. Now, in both the cases, you will go for troponin levels. In both the condition, in both the condition. It's an emergency. Won't ECG delay the chance of survival? How will you get to know that patient has a cardiac pain? It will be only with the help of ECG. You do not go blindly with thrombolysis. So you have to go stepwise. Now, after the ECG, you go for a troponin levels. Now, there are diagnosis. Troponin level will be normal or troponin level will be raised or elevated. So ST depression is there, troponin is normal. That means infarction has not taken place. Remember, when troponin is elevated, that means infarction has taken place. So this condition will be known as the unstable angina of subendocardium. This is also known as classical unstable angina. Classical angina is the subendocardial part, a small thrombus, small artery is involved there. Now troponin levels are elevated. You call this as non-ST elevation MI. Also known as previously subendocardial MI. Subendocardial MI. Now come to the transmural injury. So there will be transmural injury. Troponin levels normal or elevated. So ST elevation is there with a typical anginal pain and troponin levels are raised. This is a case of ST elevation MI. Previously known as transmural MI. It takes 5 to 6 hours. Then how can we interpret the troponin? This is practical thing, and practical means in the emergency. Remember, if a patient has chest pain at home, patient will never come to you at 0 minute. Remember, patient has a chest pain. Never come to you at 0 minute in the emergency. Patient first take antacids. Patient then take Pudin Hara. Then patient will take Baba Ramdev medicines. Then take Digene. And when there is no relief, on an average, patient has wasted 8 to 10 hours at home only. So it is the onset of the symptom and to the presentation on an average it is 8 to 10 hours. This is in Indian scenario. So by that time troponin will be elevated. Now come to the scenario where ST elevation is there and troponin is normal. So this diagnosis will be a case of a transmural angina. So this angina all of you know by the name of Prinzmetal angina. Also known as variant angina. So this is the flow chart of all the ischemic heart diseases. This is a flow chart of all the ischemic heart diseases which you will be getting, and you have to make a diagnosis of these conditions. You have to make a diagnosis of these condition, because the treatment of these condition dependent on the particular diagnosis. If you miss the diagnosis, you will be giving a wrong treatment. You will be giving a wrong treatment. So these are the four conditions. These are the four conditions. That means unstable angina, non-ST elevation MI, Prince metal angina, and ST elevation MI. Four condition. So now hopefully it will be clear to you for these conditions. Now the practice question to you for the wall of the MI. Why angina is called unstable angina? Remember, the unstable angina means the recent onset of angina. Recent onset of angina is always labeled as a unstable angina. Angina which is having a chest pain increasing in frequency and severity is also known as unstable. Unstable because the risk of the arrhythmias are very high in these cases. So the recent onset of angina is unstable angina. Angina increasing in frequency and severity is also unstable angina. Now coming to the diagnosis. The diagnosis of wall of the MI. Now look at this ECG, and remember these localization of MI ECG, not only they are important for your final year. Indeed, some of you have given your final year exams, and there is the spot question which ECG strips is given to you, and you have to make a diagnosis, not only for final year students as well as for PG entrance view. These ECG are important. Localization of the MI. So if you see this MI, so if I can slightly zoom. So in this condition, the wall of the MI, remember one very basic thing is, whenever you are getting ST elevation as well as ST depression in the same ECG, listen to the statement carefully. If you are getting a ST elevation and depression in the ECG, this will be a case of ST elevation MI, and ST depression you assume is reciprocal changes. So if I can see what is the MI, yes, this is a inferior wall MI, because in this ECG you see lead 2 is showing ST elevation, lead 3 and AVF, they are showing the ST elevation. Now look carefully the other leads. In the other leads, limb leads, one is showing ST depression. One is showing the ST depression, and AVL is also showing ST depression. So remember, this is inferior wall MI. inferior wall MI, and there are reciprocal changes in 1 and AVL. They are reciprocal changes, reciprocal ST depression in 1 and AVL. So the artery affected here is the posterior descending artery. Posterior descending artery. Why not acute pericarditis? Because in acute pericarditis, ST depression is not seen. Reciprocal change is never seen in acute pericarditis. So there are many differences with the acute pericarditis. Now come to, so the diagnosis here is inferior wall MI. Now come to the next diagram. Next diagram. So let me see who can make it a correct diagnosis. Which wall MI is this? Right ventricle MI, no. Septal MI, no. Lateral wall MI, no. It is, yes, very good. It is a posterior wall MI. How you have suspected? You have suspected the posterior wall MI because there is ST depression in lead V1, V2, V3, V4. Even the ST depression was seen till V5. So there was ST depression in these leads. So there can be a possibility of subendocardial MI of these leads or angina of these leads, or maybe reciprocal changes. And when we did the V7, V8 and V9, here in this example, V8 and V9 leads are given. Leads are given, and you can see very well there is ST elevation. There is ST elevation. So this is a case of a posterior wall MI. This is a case of posterior wall MI. Now come to the next one. So most of you have got this as a correct answer. This is a case of posterior wall MI. Let me see in the next one. In this, what is the wall of the MI? How to do the MI ECG? We are doing the MI ECG. So it is anterolateral MI, anterior wall MI. No, this is not anterior wall MI. You can look carefully. This is a case of right-sided leads. Look carefully. Look carefully. R word is written. So this look like a anterior wall MI, but no, this is not an anterior lateral MI. This is a case of right-sided lead, and the most sensitive lead is V4. So you can see the ST elevation is seen here. There is a ST elevation. So this is a right ventricle MI. right ventricle MI. And now see the anatomy, applied anatomy. Right ventricle is supplied by a branch of right coronary artery. So my question is, which other question, which other wall MI can also be present? If right ventricle MI is there, if the right ventricle MI is there, that is a right marginal. So if right ventricle wall MI is there, right ventricle MI is there, which other MI can also be present? Which wall can also be affected? Which wall? Inferior wall. Yes, it will be inferior wall. So in that case, if we look at the same ECG, look at the same ECG, and in this same ECG you can very well see that there is ST elevation in 2, 3 AVF also. Yes, there will be ST elevation in 2, 3 AVF also, indicating a inferior wall MI, indicating a inferior wall MI. And finally, so last question of the day, ECG based. Which wall MI is present here? Which wall MI is present here? Yes, this is a case of the ST elevation is seen in V2, V3, V4, V5. So this is anterolateral MI, anterior wall as well as the lateral wall MI is present. Yes, this is anterolateral because V5 is also affected here. V5 is also affected here. And how to prove that lateral wall is also affected? You look at the one end AVL, they will also show ST elevation. Anterolateral, lateral is also affected here. So with this we finish with the class for today, and in the tomorrow class we will do the management of these ischemic heart disorders, management of angina, management of myocardial infarction, and then we will finish with the ECG topic, how to approach the ECG, the questions on the ECG, and the basic 5 which is remaining of the ECG. So tomorrow we will finish those classes.